Welcome to this explainer. Today, we're unpacking a really fascinating and, frankly, increasingly urgent topic in global health. It's called polypharmacy. Now, that might sound like a heavy medical term you don't hear every day, but I guarantee it's something that likely impacts you, your parents, or your grandparents right now. We're going to dive into the exact tipping point where the medications designed to heal us can actually start working against us. It's a super critical balance, and the data we have on this is absolutely eye-opening. Let's get started. Here is a quick look at our agenda for today. 1. What is polypharmacy? 2. A global health concern. 3. The prescribing cascade. 4. When medicine causes harm. And 5. Strategies for safety prescribing. So, before we get into the strict clinical definitions, I want you to just take a second and think about a really simple question. How many daily pills are too many? Seriously, take a mental inventory of your own medicine cabinet right now, or maybe picture the kitchen counter of an aging relative. You've got a pill for blood pressure, maybe one for cholesterol, something for joint pain, an acid reflux tablet, and hey, throw in a daily vitamin. It adds up remarkably fast, doesn't it? But at what point does that innocent daily routine cross the line from helpful medical management to a potential health hazard?
Section 1. What is polypharmacy?
In the clinical literature, polypharmacy is most commonly defined as the concurrent use of 5 or more medications daily by a single patient. 5. That's the magic threshold where doctors and pharmacists really start to pay close attention. But, and this is absolutely crucial, it's not just a simple math problem. Nobody wins a prize for taking the most pills, right? The World Health Organization emphasizes that our focus shouldn't just be on a strict pill count. Instead, we need to focus on evidence-based practice and clinical optimization, basically asking the question, are these 5 or more pills genuinely the best, most optimized treatment path for this specific person? Because of that, it's really important to understand the difference between appropriate and inappropriate polypharmacy. Not all multi-drug regimens are bad. Appropriate polypharmacy happens when multiple medications are entirely, 100% clinically justified. Think of a patient dealing with complex, overlapping chronic conditions. Things like diabetes, heart disease, and asthma all at once. They genuinely need those medications, and their use is optimized according to the absolute best medical evidence. But on the flip side, we have inappropriate polypharmacy. This is characterized by the use of totally unnecessary medications, drugs with no clear clinical indication, or medications that might actually be doing more harm than good.
Building on that, medical professionals actually break this down into 4 distinct categories. We just covered appropriate and inappropriate, but look at the third category here, hyperpolypharmacy, also known as excessive polypharmacy. This specific classification is triggered when a patient is taking 10 or more medications concurrently. 10, literally double the baseline. Then, there's a highly frustrating, frankly purely systemic issue called pseudopolypharmacy. This is basically a phantom medication burden. It happens when a patient's medical record is just straight up wrong, erroneously stating they're taking more medications than they actually are. As you can imagine, that can lead to incredibly confusing and dangerous clinical decisions down the line.
Section 2. A global health concern. Now, you might be thinking this is a rare niche issue. It's not. A staggering 37% of the general population worldwide experiences polypharmacy. Over a third of the global population is taking 5 or more daily medications. When you think about the sheer volume of drugs being manufactured, prescribed, and consumed globally, the logistical and biological scale of this phenomenon is truly massive. It's everywhere. And here is where we see the burden get really heavy. When we look at older adults, specifically those aged 65 and older, the global rate jumps to 45%, nearly half. But the statistic that should truly give us pause impacts our most vulnerable. For older adults living with dementia, the prevalence skyrockets to 62%. Think about that for a second. These are patients who may really struggle to communicate side effects or manage complex daily dosing schedules on their own, making the risks exponentially higher. We also see a massive variance depending on where a patient is actually receiving their care. In standard community settings, like your local neighborhood, about 20% of people are experiencing polypharmacy. But in acute hospital settings, that number surges to approximately 52%. Why the huge jump? Well, because in a hospital environment, patients are often treated for immediate severe issues, and new medications are rapidly layered right on top of their existing at-home prescriptions.
Section 3. The prescribing cascade.
So what is actually causing all of this? The rise of polypharmacy is basically driven by a perfect storm of 3 factors. First, patient factors.
We're living much longer, we're aging, and we're developing multiple chronic conditions simultaneously, which doctors call multimorbidity. Second, clinical practice. Doctors often follow very strict clinical guidelines designed for just a single disease. So if you have 4 diseases and the doctor follows 4 separate single disease guidelines, your medication burden just explodes. And third, system issues. A lack of coordination between multiple specialists and poorly updated medical records means the left hand doesn't always know what the right hand is prescribing.
All of these underlying causes build into one of the absolute most dangerous drivers of inappropriate polypharmacy. It's called the prescribing cascade. It's literally a domino effect. Let's walk through it. Step 1, a patient takes a medication. Step 2, that medication naturally causes an adverse side effect. Step 3, and here is the critical failure, instead of recognizing it as a side effect of the first drug, the doctor misdiagnoses it as an entirely new medical condition, which leads to step 4. A brand new drug is prescribed just to treat the side effect of the first drug. You can easily see how this spirals completely out of control, resulting in a mountain of pills.
Section 4. When medicine causes harm. The crucial takeaway here is that more medicine does not always equal better health. In fact, polypharmacy carries severe, tangible risks. First up, adverse drug events, or ADEs. Simply put, the more drugs you take, the higher the risk they will chemically interact with each other in dangerous ways. Second, and this is highly concerning for older adults, is physical harm. Polypharmacy is directly linked to a higher incidence of functional decline, frailty, and falls. A dizzying drug interaction can lead to a broken hip, which changes a patient's life forever. This physical toll inevitably drives up the third category, healthcare utilization, meaning way more emergency room visits and hospital readmissions. And finally, the economic impact is just massive, completely draining healthcare systems through the sheer cost of unnecessary drugs and the incredibly expensive medical care required to fix the adverse events they cause. Section 5, Strategies for Safety Prescribing. Okay, so what do we do about it? The single most powerful tool we have against polypharmacy is a medical concept called deprescribing. It's defined as the planned and supervised process of dose reduction or stopping a medication altogether because it might be causing harm or is simply no longer required. Now, I really want to stress the words planned and supervised here. This is never, ever about a patient just deciding to throw their pills in the trash. That can be incredibly dangerous. Deprescribing is a highly methodical, clinically guided optimization process. How do clinicians actually execute safety prescribing in the real world? Well, they use a multidisciplinary approach. First, medication reconciliation and review. This means sitting down with a clinician and a pharmacist to regularly and comprehensively review every single pill being taken to identify the inappropriate ones. Second is patient engagement. Shared decision-making is vital here. Patients need to be educated on exactly why they are taking a drug and whether it still aligns with their current health goals. And third, doctors use specific evidence-based screening tools. Things like the Beers criteria or the stop/start criteria. These act as clinical checklists to quickly flag potentially inappropriate medications, especially for older adults. Which brings us to our final thought for today. When was the last time you asked for a comprehensive medication review? Seriously, whether it's for yourself, your parents, or someone you care for, the most important takeaway is that medication lists shouldn't just grow indefinitely without any questions asked. Armed with the knowledge of polypharmacy and the power of deprescribing, you can be a proactive advocate for optimized, much safer healthcare. Ask the question at your next appointment. It might just be the most important medical conversation you ever have.